Thank you. I want to thank AAKP for inviting us to present on our new technology. I'm with Teva Medical. We were acquired about 2 months ago from Becton Dickinson. I'm going to talk about our new way of creating a fistula. So there are over 500,000 patients on hemodialysis. And each of these patients has to go in 3 times a week, 3 to 4 hours, and they all require some sort of a conduit to connect them to the dialysis machine. There are a couple of different options for doing that, but the best option is the surgical AV fistula. And this is a procedure where the arm is opened up, the vessels are dissected out, a vein is swung over and sewn to an artery. Over time, the veins dilate and mature, and then they can use that vein to continually connect the patient to dialysis. Today, this is the best option available for vascular access. It becomes that patient's lifeline. It was invented over 50 years ago, and little has been done to innovate in this space. So today, when patients get a fistula, it's essentially the same type of procedure that they got 50 years ago. Really, nothing has been done to improve this type of access. So it's the gold standard, but it's not perfect. About 60% of these fistulas will fail, so the patient gets the procedure, and 60% of the time, they can't use it for dialysis. When they do work, they take months to mature, and during that time frame, the patient is subjected to a central venous catheter, which makes them at risk for getting infections. Additionally, to get the fistulas to work and to get them to maintain them working, it takes 2 to 3 procedures a year where they have to continually go back into the hospital, have a procedure done to open up the fistula that is shut down. So there's a need for innovation here. We need to be able to make the technique consistent so it's not dependent on the surgeon's skill, which varies drastically from center to center. We also want to make sure that more patients have access to the anatomy. Right now, there are only a few options on the arm, and once a patient runs out of that space, those anatomic options, then they're subjected to a central venous catheter. We've also heard that patients don't want to have surgery, and over 30% of patients just outright refuse because they're tired of having a surgical procedure. And lastly, as we heard from Sandeep, the cost of managing these patients is high, $37 billion, 7% of the Medicare budget, and the increasing cost of the interventions contributes to that cost. So why are these surgical fistulas failing? Well, one of the reasons is the surgery itself. The act of dissecting out the vein, torquing it over, and sewing it to the artery causes a cascade of events to happen that causes a narrowing where they're sewn together, and this causes the fistula to either outright shut down or require multiple interventions to keep it open. So what if we could eliminate the surgery and still give patients a fistula, which is considered the best option? So we invented the WavelinQ endoAVF system. So this is a system that creates a fistula for patients, but without open surgery. It utilizes 2 catheters that are lined with magnets. One catheter that goes into the vein has a radiofrequency electrode, and one catheter goes into the artery that receives the electrode. The procedure is done by placing 2 little punctures in the upper arm. The catheters are inserted, and then they're delivered down into the proximal forearm where we create the fistula into a part of the anatomy that you don't typically sew a surgical fistula. So this also creates an additional anatomic option for patients. We deliver a second of radiofrequency energy that cuts a hole from the vein to the artery. We remove the catheters, and now the blood flows into the veins, and they can be used for dialysis in a couple of months. So what are some of the benefits of this system? One, we avoid the scar of the actual procedure. And then because we're creating this in a system in the arm that's deep, where you don't sew a surgical fistula, we get a little bit different of a fistula. Instead of having one vein that you can dialyze from, you have multiple veins that you can dialyze from. And what this does is it reduces the appearance of the ropey arm that you get when you have a vein with all flow going through one conduit. We've also found that this requires fewer interventions to maintain the patency or to keep it open because we're not surgically manipulating the vessels to sew it together. And then lastly, we are giving patients an additional anatomic option, so extending the lifetime for them to be able to have a surgical fistula or another fistula if this one were to fail. So here's what the procedure looks like. There's a small puncture made in the upper arm where we deliver the venous catheter and the arterial catheter. So one goes into the artery, one goes into the vein. The catheters go down into the proximal forearm. They're lined with magnets, and so when they come into close proximity to each other, they will rotate and lock, and then we deliver 1 second of energy with a radiofrequency generator. And this cuts from the vein to the artery. And as you can see, then we remove the catheters, and immediately the blood starts to flow from the artery to the vein, and over time the veins will plump up. We do, as a last step, we coil one of the deep veins to make sure that the veins towards the surface can actually be used for dialysis. This creates a fistula that's a little bit different. You have multiple options to cannulate, so you're not being stuck in the same location every single time. And there are some advantages to that, such as the appearance of the arm. This is what it looks like 2 weeks after the fistula was created. As you can see, there's no scar where the procedure was done. And you can see that the veins are already dilating up, and that there are two veins. So you have your basilic and you have your cephalic, so you're not putting the needles in the same spot all the time. And what we're finding is that patients like these fistulas because of the appearance. One, they don't have to have a surgical procedure, so right after the surgery, all you have, or right after the procedure, you only have 2 little needle punctures, and then here we're showing out at past a year, the arm still looks pristine, so you don't have the ropey appearance of the arm where they're getting dialysis. So very little arm disfigurement. We've conducted multiple clinical studies demonstrating the benefits of the WavelinQ endoAVF. Our first study was the FLEX study, and this showed us that it was feasible to create a fistula using this technique, and that we were able to get the patients dialyzed. Our second study, the NEAT study, this was a prospective multi-center study that was powered to a surgical control arm from the literature. And what we found with this study was that we had superior maturation compared to surgery, and we had a lower intervention rate compared to surgery, and able to keep the fistulas patent out to a year. Our third study was the EASE study, and this is our next generation system. So outside the US, we are already on our next generation system, which has a smaller catheter that allows us to go into additional anatomic spots in the arm. Similar results were shown with that. And we're currently conducting a larger post-market study in Europe with 120 patients, and we will be starting a US post-market study in January, up to 300 patients. So what does the data show us? We pulled all of our data from the studies to date for a population of 157 patients, and then we also tracked the acute outcomes from our commercial cases in Europe. And what we're seeing is that we have a high procedure success, 97% in both our clinical studies and in our real-world cases, and this is the ability to create the fistula using this technique. And then in terms of the clinical outcomes, by 6 months, 75% of the patients are able to dialyze on their fistula. And the median time to getting dialysis is 2.1 months. And if you compare this to what we're seeing with surgical fistulas in the US, the last USRDS data was reporting 132 days. So we're able to shave off a couple of months because we're not having to go in and intervene on these fistulas. And then importantly, we've been able to show a reduction in CVC use. So patients who were pre-dialysis at the time of the procedure, only 15% of them needed to initiate dialysis on a CVC, really sparing them that exposure. And at 12 months, the patients who had started on dialysis at the time of the procedure, only 18% still needed a catheter at the end of the year. So what about the durability of this new type of fistula? So when we look at the primary patency, or the ability to, does the fistula need to be intervened on to keep it open, we have a 75% primary patency rate. And then in terms of overall durability, is the fistula open and still functioning? 79%. And this is favorable compared to the surgical literature. But to assess that further, we wanted to do a more robust comparison. And so we used the USRDS database, which is the big database that tracks all of the dialysis patients in the US. And we developed a matched cohort using propensity score matching. And we matched patients based on age, race, gender, BMI, and a bunch of clinical comorbidities, and then also whether they were incident or prevalent at the time that they got their fistula. And we tracked their outcomes over a year. We looked at all of the interventions, angioplasties, thrombectomies, whether they needed to have a surgical revision, whether they had to have a CVC placed, whether they had to go in and have any additional procedure done to their fistula to keep it working. And what we found was that at 1 month, already 50% of the surgical patients had to have a procedure, which was pretty astonishing. That's patients having to go in to the hospital, go and have someone take them in, disrupt their life to have an additional procedure already at 1 month. And with the endoAVF, that number was only 15%. And by the end of the year, 85% of the surgical patients had to have at least one procedure. So imagine going in and you're going to get the gold standard knowing that you're most likely going to need at least one procedure before the year is up. In the endoAVF group, this was about a third of the patients that needed it at the end of the year. So we saw a significant reduction in the number of patients who needed to have an intervention with the endoAVF versus surgery. And then in terms of the number of procedures that they need, so the last slide kind of showed you, if you're a patient, what's your risk of needing to have an intervention? The other problem with this is as soon as you get an intervention, you're going to have to go back and keep getting more. And so we looked at the total number of interventions as well, and we found that there was about a 6x reduction in the number of interventions with the endovascular fistula versus surgical fistula, so 0.6 compared to 3.4. So how do patients feel about the endoAVF? We wanted to understand, what did they think of it? And so we conducted a survey using a qualified questionnaire, the Vascular Access Questionnaire developed by Charmaine Locke out of Canada. And we found that 96% of the patients were satisfied with their endoAVF, 72% would recommend it to a relative, and 88% found it easy to use, and very few patients wanted to change the type of access that they had. As part of that questionnaire, we also wanted to understand how this impacts their quality of life. And so we asked them to score on a scale of 1 to 5 if they were bothered by certain factors of their vascular access. Are they worried about longevity? Do they have problems protecting it? Does it impact their ability to sleep at night? Does it interfere with their daily activities? Does it interfere with social activities? What about appearance and clotting and bleeding when they're in the dialysis clinic in pain? And on all of these metrics, patients rated it less than 1 or almost less than 1, meaning they were not at all bothered or only a little bit bothered. So this indicated that the endovascular fistula did not have a negative impact on their quality of life. It allowed them to kind of continue on with their daily life. So the WavelinQ harnesses patient-driven innovation. We were lucky enough to have a collaboration with AAKP. They worked with us to help us understand what it is that patients are interested in when it comes into vascular access. So we surveyed 150 dialysis patients that had a variety of different access types, and we asked them what matters most to them. And what we found is that patients are most concerned about infection risk, the durability of the access, is it going to last? Are they going to need to go in and have another procedure or an intervention to keep it working? And then how will it impact their daily activities? So in all of these areas, we feel this is a place where the endovascular fistula can actually make an impact on the items that matter most to patients. We also looked at patients who never received a fistula to understand why were they not receiving it. And what we found was that the invasiveness of the procedure and the durability of the perception of the durability of the access were the reasons that patients chose not to get a fistula. And then importantly, when asking patients on who didn't get a fistula, would they have gotten one if there had been a different option? 86% of patients said that if there had been a less invasive option that didn't require surgery, they would have gotten a fistula instead of a CVC. So in summary, we've developed a new technology that reduces the need for interventions, it reduces cost, it improves patients' quality of life, and it gives patients another anatomical option for a fistula. It is now commercially available. We received FDA market authorization in June of this year. But we still have a long way to go. In order for patients to have access to this therapy, we need to figure out how to get it paid for. This past August, we asked CMS to create a new technology APC and billing code to allow payment in the hospital outpatient in ASC setting to really eliminate that financial burden so that patients can actually receive the therapy. We're still waiting for CMS to respond, but we're hoping that with the help of patient advocates, physician community, and the whole dialysis network that we can make sure patients have access to this new option. Thank you.